how big is the avoidable spend market in pediatrics from a cost perspective in the national market, or is it more contained? And what specific conditions are driving that category of avoidable spend?
The pediatrics market, around 75 million children in the United States, around 4 million new children are born every year. And the market from a payer perspective is split about 50-50 between commercial insurers and government insurers through Medicaid or CHIP, the Children's Health Insurance Program. The government is actually a major player in children's health. Overall, the total market is around like $375 to $400 billion of spend on children's health in the US every year. What we see as like one of the big challenges in children's healthcare is, especially for children covered by Medicaid or CHIP, there are significant access barriers to access to high quality care that exists.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. Welcome to the next Analyzing Healthcare podcast, brought to you by Scale Community. I am pleased to be joined by Chris Johnson, the CEO of Bluebird Kids Health, a value-based care focused MSO in the pediatric space. And Chris was formerly, among other roles, the CEO of Landmark Health, an in-home services business that was ultimately acquired by Optum around 2021. Is that right, Chris?
Yes, 2021.
So Chris, welcome to the podcast, and very excited to explore Bluebird Kids Health and what you have going on in the pediatrics value-based care market. So thanks for joining us.
Jason, it's great to be here, and thank you for having me. I'm looking forward to the conversation.
So before we jump into Bluebird, maybe we can just spend a couple minutes on the concept of pediatrics value-based care. And I think for a lot of us, the concept of value-based care in the adult market is fairly well known. And we think of certain KPIs around avoidable hospital admissions, and we think of high-cost orthopedic or spine procedures and high-cost cancer care and chronic condition management. And there's a established market for how these services are reimbursed in a risk-based environment and bonus environment. Familiar with the government programs delivered through Medicare and CMMI around incentive structures. Much less familiar with that in the pediatric market. And so would love to just understand at a market level, how big is the avoidable spend market in pediatrics? Does this sort of rise to the level of a meaningful issue from a cost perspective in the national market, or is it more contained? And what specific conditions and circumstances are driving that category of avoidable spend?
Yeah, no, it's a great question. To some degree, the end goal is very similar to senior medicine, which is better patient experience, higher quality health outcomes, more happy, healthy days at home. The route through which you get there is a little different. So maybe I'll even take like a half a step back. Just thinking about the pediatrics market in general, there's around 75 million children in the United States. Around 4 million new children are born every year. And the market from a payer perspective is split about 50-50 between commercial insurers and government insurers through Medicaid or CHIP, the Children's Health Insurance Program. And I think that's like a fact that a lot of folks aren't super familiar with. I wasn't until I started to get more involved in kids, but the government is actually a major player in children's health in this country. And overall, the total market is around like $375 to $400 billion of spend on children's health in the US every year. What we see as like one of the big challenges in children's healthcare is, especially for children covered by Medicaid or CHIP, there are significant access barriers to access to high quality care that exists. Those exist in a couple ways. Like one is generally Medicaid is seen as not as high a payer for healthcare services. And that's true in kids as well as it is in adult and senior medicine. And so you have just fewer folks that are in the network who are willing to see children. Fewer pediatricians are willing to see children. When they are able to see children, a lot of times they have to limit the amount of children that they see on their panel. So in theory, every pediatrician in the US would have to have 50% of their panel being children from Medicaid and 50% from children with commercial coverage in order to make sure every kid has access to care. Generally, you see the number of children on a pediatrician's panel at a much lower level, oftentimes, 20%, 25% of a panel versus the 50% that is commensurate with their proportion of the population. And then that drives like further inequities in terms of what we call pediatric care deserts. So oftentimes what you'll see in almost every major metro area, if you start to map out where the kind of the lowest income zip codes that account for about 50% of the children and where the highest income zip codes that account for 50% of the children, you see about a 2-to-1 discrepancy in terms of the pediatricians per 1,000 children, with there being 2 times as many pediatricians in the high income zip codes versus the low income zip codes. And so there's also kind of this structural, social determinant, zip code is your destiny, a dynamic that starts to play out in kids' health. And so what does that mean? What we see is that children on who are especially children covered by Medicaid end up using emergency medicine at 6-7 times the rate of children on commercial insurance. They also have much higher rates of inpatient utilization. And that's not due to the fact, that's one dynamic. And then from a quality outcome perspective, much lower. You often see very low like wellness visit attainment, very low like quality score performance for these children. And that doesn't necessarily drive near-term costs, but a lot of the purpose of children's health in this country is actually to help set people up on a great trajectory through their lives. And missing on those it's just a disservice to the children. It's a disservice to the future of our country.
Are they utilizing the emergency rooms for emergent care that could have been treated at the pediatrician's office, but they didn't have access to that pediatrician? Or are they using the emergency rooms for just your annual physical wellness type activities?
Yeah, I'd say more the former, Jason. So a lot of folks just like cannot get access to a pediatrician. It's not that they choose not to, it's that it's some of those barriers that I talked about at the beginning are real. And so what happens is getting access to proactive wellness care can be very, very challenging for children. So what happens is a lot of times the parents, once there's an emergent issue, respiratory distress, whether that's allergy or asthma, sometimes a behavioral health issue, if that's, thoughts of self-harm or ideation or major depressive issues, those often, there's nowhere to go except to go to the emergency room for many children and their families. And that's what we really see is driving those much higher rates of emergency room utilization. It's in many communities, it's like the only place that they can find access to care. And we know that those are not the right places to receive treatment for those conditions. Emergency rooms do incredible things, right? And it's an incredible asset to have in a community, but it's not meant to diagnose and provide treatment options for a 6-year-old who's developing asthma or might have an allergy. Those children really need a longitudinal provider who can work with them, who can be there available whenever there's a question that a parent has and has a regular cadence of checking in to make sure that they're keeping up with their care plan. And so the ethos of Bluebird Kids is we actually build new pediatric primary care clinics in these pediatric care deserts. And then we have a technology platform that we've built that allows us to provide like really exceptional, like next generation pediatric care that's both efficient, but also is able to help us manage chronic conditions like asthma and allergies. We integrate behavioral health into our care model to make sure that the kids that need access to those services are actually able to get access to them proactively. And then we are available, 24/7 to make sure that whenever a parent or sometimes the patient themselves has a question or concern, they're able to get that addressed quickly versus needing to go to an emergency room at 10 o'clock at night. And just an ability to also bring people into the clinic if they need to be seen on kind of same day, next day cadence that's often not available to lots of children across the country.
For the 50% of the pediatric market that's in the government space, roughly 50%, is that predominantly managed Medicaid, or in pediatrics, is it more common to go directly straight government care?
It depends a little bit on the state, but generally we're working on like with managed Medicaid population. So we're primarily operating in Florida right now, where all children, just about all children, are in a managed Medicaid product. in the state.
So it sounds like a pretty sizable market, 375 to $400 billion. And it sounds like in some ways the solution to this challenge is relatively more simple than in the adult market. It's just about providing care and access to care in these deserts that you just mentioned. As you are an adult, you can talk about the range of different complications that you may have, and so you need a much broader ecosystem. It sounds of specialists and care providers and care programs to sort of manage the cost. Feel free to push back on that if you disagree, but
Yeah, well, I don't. I'd say it's different, right? So I think I'll give you a controversial hot take. I think a lot of value creation in senior medicine, right, has changed over the last 18 months, where a lot was historically on complete and accurate documentation, and that drove risk adjustment for many of those populations. And then maybe it was on utilization management, which was really often making sure that people didn't access unneeded care. But I don't think that there were too many models that actually showed we're on a non-risk adjusted basis, driving fewer ER and inpatient utilization. I think that's actually like a really, really hard thing to do. I think most stats that you see are, hey, after our risk scores increased by 30%, we saw a 30% decrease on a risk adjusted basis in our utilization patterns. So I'd push back. Like the interesting thing in managed Medicaid is there really isn't a risk adjustment mechanism. So in order to actually drive utilization improvements, you actually have to drive utilization
yeah,
improvements.
no doubt. I think we can debate the effectiveness of the adult programs and why they're successful and what success means. But I
Yeah.
think as you age, the rate of cancer, I mean, there's certainly pediatric cancer cases, but there's probably a higher number of cancer patients as you get older. And so just in order to be successful in the way that you're describing success on a non-risk adjusted basis, reducing the cost of care, I think that the challenge with adults is extremely hard, and to the point where I'm not sure how successful we've really been on a non-risk adjusted basis. In the pediatric, space that you're talking about, it sounds like a lot of good can be done by simply providing accessible primary care
Yeah.
in that market.
I
Doesn't
think,
solve for everything, but it sounds
yeah.
like 80 rule you can solve for by providing reliable, accessible care.
I think it had reliable, accessible care, but I think it also has to be like high quality. So, right.
Sure.
And I'll give you an example. A lot like what we see is like very, very large driving our behavioral health diagnoses.
Mhm.
And like I said, asthma, kind of respiratory distress, allergy. The former, one of the biggest challenges, it's actually almost the complete opposite of what you see in adult medicine, is that folks don't have access to behavioral health. And so most pediatricians, if you go to their offices, they themselves are not comfortable managing behavioral health. And then if they have a child who's on Medicaid, it can be very, very challenging to find someone who will actually receive a referral
I want to
for
I
that.
want to come back to that in 1 second on the sort
Yeah.
of under the hood of Bluebird and what allows
Yeah.
you to deliver effective value-based care. But I just have one contextual question before we jump into
Yeah.
that. So the market's fairly big, 375 to 400 billion, and the
Yeah.
problem is addressable or seemingly addressable. How receptive are the payers in the managed Medicaid space to this topic of pediatric value-based care? When you went to present to them, was this something that immediately resonated and they were happy to work on incentive structures to reward you for avoiding and reducing the cost of care that would then allow you to provide your providers with the incentives to go into these markets? Or did you find that pediatrics was lower in sort of the priority order because it's just a smaller market relative to some of the adult-based care that they're focused on?
Yeah, I think it's a little bit of a question of like what's your unit of question. I think if you're going to a managed Medicaid plan, especially in non-expansion states, children make up the vast majority of their membership. I believe in Florida, over 60% of the Medicaid membership are children under 18 years of age. I think in Texas, might be north of 70%. So don't quote me on those, but I believe
Sure.
that's the level. And so kids are a large portion of someone who's running like a Medicaid managed care plan,
Mhm.
not a D-SNP plan or kind of like a plan that's really focused on medically complex adults, but like your core Medicaid plan is managed Medicaid is very focused on kids. And increasingly, I think what you're seeing from the states is a real push for having a network that is high quality, for actually hitting quality outcomes and quality metrics. And we're seeing a lot of states actually requesting and setting quotas for the percentage of the membership that are in value-based care or advanced payment model arrangements with that network. And so we found the MCOs to be receptive partners to us, and we really do look at it as a partnership. Like, we think we can kind of create win-win-win scenarios where we're creating a win for the patient because they're getting more access to care. It's higher quality care. It's keeping them home, keeping them healthy, and it's services that they didn't have access to before. When it's a win for the payer, they're getting higher quality outcomes. That's what the state is asking for them. They're seeing more efficient utilization, so they're seeing their membership get more primary care and spend less time in the hospital. And then for us, it's allowing us to generate surpluses that we can use to reinvest in care management programs, technology programs, outreach and engagement programs, social care programs that are really necessary in order to successfully deliver on that promise.
Let's get into Bluebird. So it sounds like you're focused on the Florida market today. Can you give us a sense for number of locations, number of patients in your footprint today?
Yeah, so we're today operating in Florida, 6 locations today across the east coast of Florida, about 30,000 patients under management today. We've been around for about 18 months. And continue to grow our footprint in Florida over the next few years, really trying to become a core part of the children's healthcare fabric in the communities that we serve today.
And back to some of the programs that allow you to be effective from a value-based care perspective. You mentioned behavioral health. You alluded to a technology platform that you have invested in building. What are the core components from a service perspective, clinical and infrastructural perspective that allow you to deliver effective value-based care?
Yeah, a few things. And I think a lot of this might sound similar to like a senior models that you hear, but first is around like you have to have a great clinical model. And so we've invested a lot of energy in being able to integrate not only physical health, but behavioral health and social care into our core model, because we know that those are all drivers of successful healthcare outcomes. And that on the behavioral health side means actually training all of our providers in behavioral health, but also employing behavioral health and building kind of a behavioral health care management capability internally. And on the social care, it's actually working with folks across the community to make sure that a lot of the social services that exist are actually more closely integrated to the children and the families that need access to those services. Some of our office locations, we actually have community groups that actually kind of use physical space in our clinics as access points for their services. That's a win for them and also a win for our patients who can get better access to it.
The
We
behavioral
then
health are employed by Bluebird directly, or is that a partnership model?
employ directly. And again, it's especially on the Medicaid side, it's really an access challenge. There are a lot of statistics that have looked at commercial coverage versus Medicaid, like what's the likelihood of a referral being able to be completed.
Mhm.
It's about 87, I think it's 87% less likely that a behavioral health referral is completed on a child who has Medicaid coverage versus commercial coverage. And so you just can't, the network out there just is not able to actually deliver those services. And that's the lack of access is actually what drives a lot of the downstream challenges that you see. We said, hey, like we need to insort, the kids need it. It's the right thing to do. But we also believe that it actually helps to drive performance and total cost of care arrangements by helping keep people out of the hospital.
I think I cut you off. So behavioral health, social services. Was there anything else you wanted to highlight in terms of the components of the value-based care program that you built out?
Yeah, so in the clinical model, the last piece is an asthma management capability and respiratory distress capability that has to do with both education in the clinics, tools that we provide, digital tools that we provide to folks as they go home, and then kind of a care management system that is making sure that folks are picking up meds, being able to understand when there are certain triggers, so that we can outreach folks to kind of remind them, hey, it's pollen season, et cetera. This might be a time to be at kind of high on high alert to make sure that you're proactively have your meds. Call us if you have an issue, et cetera, so we can help keep you healthy at home. And then we wrap all that with we have a digital engagement platform that we've developed so that there's seamless access. You kind of have access to us 24/7, 365. Whenever anything comes up, we really want you to call us first, be the trusted partner. And we've built a lot of tools, Jason, then on the back end, right? That's kind of the front end clinical experience. I should mention we have these modern, easy to access retail locations. So like in like local shopping plazas, 3,000 or 4,000 square feet, bright windows, modern setting that's easy to get to.
Yeah.
Then kind of on the back end, you have to build a value-based care chassis. So we built technology that allows us to manage rosters, drive outreach and engagement for members. We can take attribution from health plans and actually bring those members into the clinic at really efficient rates. So usually, within 90 days, we're seeing north of 55 to 60% of folks that are attributed to us have actually come and completed a visit in our clinic. So we've had to build the infrastructure to be able to actually bring those folks that are being attributed to us in a risk arrangement into the clinic. And then a lot of tools to better manage quality outcomes for those kids, wellness visit attainment, various developmental screens that we focus on, immunization rates, asthma management, post-discharge visits that are actually unique to kids. Many of them, like adults, have kind of their own slate of quality measures. There's a somewhat unique set of quality measures for children that are also unique in that a lot of them are tied to birthdays, not tied to calendar years. So there's kind of a different type of complexity in managing a quality program. And then obviously, like our kind of care management program, where we're actually ingesting all of our payer claim data. We're identifying high risk and rising risk patients and making sure to outreach, bring them into the clinic and help prevent any sort of like escalating conditions that could drive not only increased spending, but for a poor kid to like not be able to sleep in their own bed at night, having to spend a night in a hospital.
Are you leveraging any kind of remote monitoring, any type of in-home services, or that's not as relevant in the pediatric care model you've built out?
I think for certain kids, those things are very relevant. Our like core focus in terms of our program are kind of like I call them like the 99% of kids that are like generally out living in the community. There are some like really, really medically complex children that need really specialized services in the home. We work with those children, but we really limit our exposure there or not our exposure, our role to providing the primary care services. And then we know there are partners that need to provide really great in-home private duty nursing or skilled nursing services. There are DME suppliers. We don't focus on taking those into value-based arrangements for ourselves because there's so much happening outside of primary care there that we think those require really specialist models
I was going
to
to
do
ask
well.
about the specialists. So you mentioned, in-home and you mentioned DME. How about just specialists, whether it's, ancillary services, radiology, or just any type of specialist, like hematologist or any other specialist? Are those in-house or through partnerships?
We do all those through partnerships. So look to find really great partners in each of the communities where we operate, where we're able to not only partner with them to, again, there's kind of this commercial Medicaid divide. Like we have a lot of commercial members. We'd like to be able to send them to high quality providers. We also want those providers to be open to seeing some of our kids that are on the Medicaid fee schedule. And so having that collaborative relationship. And then we actually employ a care coordination team that actually helps us set up and schedule those specialist appointments because we know how hard it can be to actually complete those appointments for many families. And again, especially families on some of the government payer programs.
So quite a robust program. Let's talk about results and challenges. So on the results side, what are the results in terms of health outcomes, in terms of cost of care that Bluebird is most proud of? And on the challenges side, what are the types of challenges that despite having all of this program built out, still prevent you from getting even better results on either health outcomes or cost of care?
Yeah, I'd say that we've been really excited about the health outcomes so far. So it all starts with having folks be able to come into the practice. And so we're regularly seeing, over 90% of folks come in for at least their annual wellness visit with us. So they're coming in, they're seeing their provider, they're having that longitudinal relationship. And that allows us to do really well across many of those really preventative or kind of prophylactic quality measures that we're measured against in terms of immunization rates, developmental screens and interventions, et cetera. So we've been really excited about that, where we're consistently, in the top decile in terms of those quality measures, but relative to kind of the community averages where we work. And then furthermore, able to drive reductions in emergency room and inpatient utilization, generally seeing both of those decrease by over 50% relative to the community average. We believe because one, we're making sure that we're always accessible to our members, we're getting them in, and then we're deploying or giving them access when necessary to high quality clinical programs, managing their asthma, getting them access to behavioral health services. And again, like always, whenever they call, saying, call us first, and we're here to be able to help you if we can. We obviously believe in hospital medicine, but we believe many things can be better managed outside of the hospital setting.
And how about challenges?
Challenges, my goodness, there are always challenges.
Yeah.
I think like one of the macro level, you don't hear a lot about kids' health, right? It's not usually on the radar of health reform or policy experts. And that just alone is like a real shame. It's a huge population. And I think it's an area where we've shown you can have the most differentiated impact on like the long-term health outcomes of children. So just one of the things we're very focused on is increasingly how do we get more share of mind from policy folks on kids' health and the importance of making sure that those services are available, because the lifetime ROI for our country is like very, very, very well known. So there's that challenge. I'd say the second challenge is the amount of care providers, especially for children who are on government programs, is low. Like it's really hard to find specialist care, not just behavioral health, across all specialties. It's not easy to find, and you have to work really hard to find providers you can work in concert with. Kind of create. It's not even creating a preferred network. It's creating a set of relationships of folks that know that you're making appropriate referrals and are mission aligned to be able to help you co-manage those children through challenging dynamics. And all of that's driven right by like just the decision we've made around rate. We've decided that on the managed Medicaid side, we pay lower rates to a lot of our outpatient services than we do in other health modalities, and somewhat ironically, it drives really bad outcomes that are more costly and less effective. And so what we're trying to do is create value-based care payments, be able to actually create the incentive to invest more upstream to prevent kind of the ills of some of the fee-for-service structure of the system.
Yeah, it's a good segue to talk about reimbursement. So how much of your business is value-based care reimbursement and within versus fee-for-service? And within value-based care, is it right to think about it the same way that I think about some of these global risk MA organizations in Florida? Or is it more of a bonus structure, value-based care?
Yeah, so we're about 50-50. About 50% of the business is our members are commercial payers, and about 50% are Medicaid. And just about all of our Medicaid payers, we are in risk arrangements, and those that we're not, we're like on the path to moving into risk arrangements. On the commercial side, we have more of a bonus structure with some of our partners, where when we achieve quality outcomes or sometimes utilization outcomes, we're able to get like a bonus payment associated with that. And with our managed care partners, we really try and, I'd say, mimic a structure where there's a kind of a target that's a percentage of premium target, and then that there's either full risk upside and downside off of that, or a shared savings up and down off of that with a different allocation. But we really believe that you can move the total medical expense dial and try and contract that way.
The pediatric Medicaid side, is there a strong attribution model? So if I think of adult Medicare, where you sign up for your primary care provider, on the Medicaid side, I don't believe that's the case. How about on the pediatric side?
In terms of having to choose a
primary care, yeah.
Yeah, so I believe you're required to choose or be assigned to a primary care provider to be enrolled in Medicaid, at least in Florida, where I'm most familiar. And I'd say a lot of that is like sometimes you get assigned to a provider, but you've never met that provider, right? Like the plan might auto assign you if you don't bring your own provider. What we try and work with some of our health plan partners to do is say, hey, like we're always open to seeing more members. If there are folks that become eligible, and join your plan. If you assign them to us, we'll actually like outreach, bring them into the practice, let them know who we are. And so we're kind of like helping give like a little bit of like white glove service to those members so they know that they have access and they're welcome into our practice anytime. That's a portion of like some of our how we grow on the managed care side, but we also we accept people walking through our doors. So we have like direct to consumer relationships. If anyone walks through our door, we're broadly contracted with all payers. We'll be able to see them, help them reassign their PCP if they want to work with us.
About school, any partnerships with schools, or other organizations like schools?
Yeah, yeah. I'd say yes. We work with a lot of I'd say like early on, we work with like new moms groups and hospitals. We work kind of the maternity wards. Then we work with like daycares around for kids who don't have access to care. And then we do work with schools. We work with some organizations that are broadly like school health solutions as like their primary care partner. Um, uh, it's interesting. I think schools are kind of the holy grail in terms of kids' health. It's almost like you have like two complicated systems coming together. You have like the healthcare system, which you and I spend a lot of time in, and we know there's a lot of opportunity for. And then you have like the school system, which also is like kind of a messy thing. And so that I think we haven't yet seen like the real interface between the two that's scaled, but it's an area where we spend a fair amount of time, especially in our local communities, making sure that the teachers, the nurses are aware of who we are. If they see a need, they know that like we're available to them. And then we're increasingly looking at, are there partners who are figuring out how to kind of create that link into the school that's like more scalable over time.
Yeah. I'm sure there are a lot of challenges building a business in a heavy Medicaid with a heavy Medicaid focus, but one of the benefits I would think, or one of the interesting elements, I don't know if it's a benefit, is that you're providing care to constituents in your local community, in your local state, and the payer is also state specific. The ultimate decider of the reimbursement is the state. Whereas if you're providing Medicare, whether it's government or managed, it's the entire country, and you're a much smaller portion of the pie. And so you would think that that would lead to a lot of more collaboration between the different stakeholders, given that it's a much smaller market, given that the constituents are much closer to home in terms of who they're electing, and so on and so forth. Do you find it to be a collaborative environment where there's an opportunity to work with the state Medicaid program to help them shift policy, to help them get better outcomes for the state from a care perspective and a cost perspective? Or is that not something that's really reached the radar?
Yeah, I think we're still a young organization, so I'd say like right now, Jason, we've been very focused on we know the Medicaid plans are working with the state. Like, let us work with them to see how can we really like help you succeed in those relationships we have. In the long run, I think what you're saying is right. Like there is a lot of opportunity. These are big state programs. It's oftentimes like one of the biggest programs in the state is like their Medicaid program. We hope to be able to help shape and influence that as we continue to demonstrate strong results and continue to get to the scale that's necessary to really say, hey, we're not only transforming care in this particular community, but we're a partner that's helping to hopefully improve not only the health outcomes, but just the trajectory of the youth population in your state. I mean, that's the kind of the magical thing about kids is if we're doing if we're doing things right, I think the number of like positive externalities that come out of getting kids the right access to care is like insane. You're catching kids who have vision challenges earlier. You're getting them glasses. That means they don't become disenchanted when they're trying to learn to read in school. Therefore, they actually learn to read and they graduate versus never learn to read and decide to drop out of school, or being able to catch someone with dyslexia and get them the appropriate resources so that they can stay in school. There's so many things where like in this kind of period from like 4 to 14, 15 years old that we can catch on the health side that has just these amazing externalities that come back into the community. And that's what motivates me. That's what motivates our team. We're building a business that's focused on like the clinical care delivery, and that needs to work. But if we do that well, the societal good that comes out of it is really huge and exciting
Look, it
for us.
reminds me to some extent of my former business. Before Scale, we were building ambulatory surgery centers, and most of them were in New York. And so the state was a heavy player in the CON approval, and Medicaid was a big payer for our network. And we periodically drove up to Albany, and we interacted with the Department of Health and the other key players that were involved. we never drove down to DC to talk to Medicare about, the reimbursements for Medicare.
Yep.
And so I think there's a potential for a more collaborative ecosystem at a state level, which creates some exciting opportunities to get to all those positive externalities that you mentioned. Another question from a Medicare perspective, it sounds like you've got a lot of runway in the Florida market. So you may be in Florida for a while. One of the downsides comparing, Medicare as the underlying payer versus Medicaid, um, is that you do face a different dynamic in each state. And I'm just wondering, with the changes going on at the policy level, particularly related to Medicaid, how much risk that creates and volatility that creates to your out of state expansion model. Is it something where, you're comfortable in Florida and you want to stay in Florida? Or do you see an opportunity to expand out of Florida over time?
Yeah, we have kind of our plans to continue to expand beyond Florida as well. I think we really believe that like density is your friend in terms of being able to build the community relationships, being able to build the operational competence to deliver like excellence every day. But we're certainly looking at other states like Texas. We're looking at states like Arizona. We're looking at states like New York, and believe that you can have this model be very successful regardless of the state, because the underlying condition is still there, that almost every state you see really efficient use of premium dollars on kids' health. Like ER utilization is very high, inpatient utilization is very high, respiratory challenges are underdiagnosed and undertreated, and behavioral health is a growing problem. And so like all of those underlying conditions, Jason, are very similar. The specific rates, yes, there's some difference state to state. Are they managed care or non-managed care states? There's a little bit of difference that we think about. Like we're very focused on being in states that have like a more managed care environment, just for easier contracting purposes. And then I think you see certain states that have really are pushing more and saying like, hey, like we're a managed care state. Like we expect you managed care organization to do more than just build a network. Like we're going to hold you accountable for outcomes. That's my love language, right? As a provider, like I want a partner that says like, I need high quality care. I need value-based care. I need to lower my total medical expense. Like that's where like we can find like a great partnership. If it's just like, hey, here's my fixed amount of money and I want to spend as little of it on you as I can, that's like
Sure.
a good petri dish for me in terms of how we think about growing. So we see it can expand to other states. We think the underlying conditions are there. The opportunity to improve trajectory and health is there. And generally it's similar players that are in most states, right? It's similar to the Medicare space. The managed Medicaid space is a handful of providers that are generally market dominant in most states.
Last question I have. You've had a chance to come in at an interesting point. So you're building value-based care. You started 18 months ago and you're in pediatrics. So you're coming in Florida, which is a state where value-based care has been pervasive. You're coming in after many ebbs and flows in that market. You mentioned, the risk adjustment has changed in terms of its relative value and emphasis in that market. And so I'm just wondering how the lessons learned of the value-based care adult market have influenced your strategy. Is it more de novo, less acquisition? Is it different types of reimbursement models? If at all, has it influenced the strategy of Bluebird Kids Health?
Yeah, I think a few things, I guess. Having been previously in a fully capitated kind of Medicare Advantage world when I was at Landmark, I think one, like a deep belief that you need to really, at your core, you need to have a better clinical model, that you understand the problem is this, I do this, and that changes, and making sure that like we're always rooted in, hey, this is like a great clinical opportunity that is improving the health outcomes of kids. So like we have to always be grounded in that. Two, we're intentionally like very broadly contracted. We want to work in deep collaboration and partnership with all of our plan partners, but we also want to make sure that we both have great relations with our commercial payers, and that on the Medicaid side, we are not overly reliant on any individual plan in the market, so that if something does happen or someone decides they have to make a different change in how they're paying rates, that we have another partner who we can work with down the line. At our core, we're not like a contracting leverage business, but we also don't want to be leveraged against. And so I'd say
Right.
like that's been a core strategy of just trying to make sure that we're broadly contracted and that we have strong relationships across multiple entities versus being like too single threaded in our growth and kind of contract strategy.
Chris, I want to thank you so much for the time. I really enjoyed learning about Bluebird Kids Health, and kudos to you for all you've built and all you've achieved at the company over 18 months. Wishing you a lot of success going forward.
Jason, I really enjoyed the conversation, and I appreciate you giving us a chance to tell our emerging story here.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.